Of you are logged in. I can see Wilfred from Nairobi. Hello from Naomi from Kerugoya, Nancy from Migori, Caleb from Siaya, and everyone across the country, Agnes from Matu, and even those who are outside Kenya. Welcome very much. And at this point, Francis, can you hear me? You can proceed.
Good evening, everyone. Thank you, Fred, for the introduction. I'm Francis Awino, and this is our second part of graft rejection. We had done the first part. So in the first part, we focused more on the sensitization and the pathways for T-cell activation. So today we look at the effector mechanism of allograft rejection. So in the effector mechanism, here we'll be focusing on the clinical stages. On the clinical stages of graft rejection. So we'll see how the hyperacute rejection present, the acute rejection present, and also the chronic rejection, the chronic phase presents. And then finally, we'll wrap it up with the prevention and see the role of laboratory personnel in prevention of graft rejection. So some of the tests that we do, and also some of the processes that the patients undergo, and also the donors have to undergo to ensure that we protect the welfare of both the recipient and the donor in this case. Am I audible, Fred? So the objectives of today's webinar is to understand the effector mechanism. As we have said, we'll go deep into the clinical stages and expound more on the prevention of graft rejection. Graft rejection can be classified on the basis of the histopathological features or the time course of rejection after the transplantation, rather than on the basis of the immune effector mechanism. So we don't classify them as either humoral or T-cell, humoral or cellular mediated, but we classify them based on the time and also based on the histopathological patterns. Like those ones which happens almost immediately, we refer to them as hyperacute rejection, and how they present histopathologically is a bit different from how acute present and that of the chronic phase. So based on the experience, and this one has been investigated using the renal transplantation or kidney transplantation. There are three histopathological patterns, that is hyperacute, acute, and chronic. And as we have said, this can be classified based on two criteria: occurrence. It can occur within minutes to hours or years after the host blood vessels are anastomosed to graft vessel. So rejection can start almost immediately. And if you just recap our first webinar, we talked about the direct pathway and indirect pathway and how they contribute to graft rejection. Where in the direct pathway, we said the allo-MHC molecule, that those ones of the donor, they interact directly with the recipient, with the recipient antigen, with the recipient T cells. And if you look at the indirect pathway, the donor peptides or the allo-MHC molecules has to be processed and then presented on the recipient MHC molecules. Then this one will be interact directly or now interacting with the CD4 of the recipient cells, where the direct pathway would lead us to acute rejection, while indirect pathway lead us to the chronic rejection. And we also saw that those ones that are mediated by antibodies, they will lead us into hyperacute rejection. So pathologically, you could see thrombotic occlusion of the graft vasculature, as we will see in hyperacute rejection, ischemia, denaturation, and necrosis. That is more of characterization of acute stroke, chronic phase. So in hyperacute rejection, this one is characterized by thrombotic occlusions of the graft vasculatures. So it begins within minutes to hours after the host blood vessels are anastomosed to graft vessels. So almost immediately, the vessels have been joined. That is, the vessels of the recipient and the donor's graft have been joined, and then the circulation continues. So if the recipient is having pre-existing antibodies, they'll start attacking the new graft vessels almost immediately. And as a result, we'll have clot formation inside the vessels of the new grafts. So that is mediated by pre-existing antibodies in the host circulation, which bind to the donor endothelial antigens. And binding of these antibodies to the endothelial will activate the complement system. Activation of complements in turns will result into injury of the endothelial cells and exposure of subendothelial basement membrane that activates platelets. Remember, the subendothelial basements will be able to secrete molecules such as thromboxane 18 and serotonin. Those ones are able to activate the platelets, and they also secrete von Willebrand factors that mediate platelet adhesion and aggregations. So that process contributes to thrombosis and vascular occlusion. So once the vascular occlusion has happened, the new grafts cannot be properly they can't receive enough blood, and so in the process they die. Irreversible ischemic damage. So this here we are just having a summary of how the complement activation takes place, the three pathways, the classical, the lectin, and alternative pathway. So in graft rejection, we are more interested in antibody-initiated pathway, which is the classical pathway. And the end result of it is the MAC, that is the membrane attack complex, resulting into lysis of the endothelial cells. And so that injury is what results into activation of platelets and aggregation and thrombotic in the and the and platelet formation at the end of the day. So in the ancient days, this was mostly associated with the ABO blood group antigens, but currently we have to ensure that both the recipient and the donor are of the same ABO blood type, and that their blood are compatible, so that you minimize the hyperacute rejection, or you minimize having antibodies. You minimize having antibodies in the system of the recipient that would attack the graft almost immediately. So once this has been addressed, the ABO typing and all that, we can still experience cases of hyperacute rejection. But in this case now, we are looking at the IgG antibodies, which are directed against the protein alloantigens, such as the foreign MHC molecules or the HLA molecules. It can also be against less well-defined alloantigens expressed on the vascular endothelial cells. So these antibodies, the recipients mostly develop them following previous transfusion. It could be previous organ transplant, that is in case the recipient have received grafts before, and maybe they were sensitized. So you look at the presensitization stage, and then also cases of multiple pregnancy. They can also be sensitized, or in the process they can develop some anti-HLA. So this anti-HLA or the IgG anti-HLA, they'll be responsible to initiate hyperacute rejection. So patients in need of allografts are routinely screened before, so you ensure that they are screened before grafting for the presence of antibodies that bind to cells of a potential organ donor. And by doing that, we'll avoid the hyperacute rejection. So that diagram just represents how the hyperacute rejection takes place, where here we are using a kidney or a renal graft. So you can see the step one where my cursor is. We have got the pre-existing antibodies, and immediately the vessels have been anastomosed, they traffic to the newly planted graft. And then in the second step, the antibodies will bind to antigens of renal capillaries and activate complements. Remember, once the complements have been activated, we have got things like C3b, those are opsonins. They enhance phagocytosis. And remember, all macrophages have got macrophages are neutrophils, they've got that receptor for C3b, the complement receptor 1, which binds C3b, and so therefore they will attract neutrophils and even macrophages to the site of these endothelial cells lining the vessels. And so that is the step 3. And then now, once the neutrophils or the macrophages are there, they destroy the cells through the lytic enzymes. And in the process also, we have got activation of platelets and von Willebrand factors, which is because they injure the endothelial cells. And that injury is what leads to secretion of things of like activation of platelets and secretions of von Willebrand factor. And in the process, there is platelets aggregation and adhesion, resulting into platelet clog or thrombosis inside that particular vessel. And that's how the hyperacute rejection takes place, which means that the vessels are blocked, and so therefore the new tissue cannot receive enough supply of blood, and in the process it dies. Ischemic damage. So that's another presentation, a better view. So we have got the endothelial cells, that is the blood vessels of the lumen lining the blood vessels of the new graft. And then we have got now the circulating alloantigen specific antibodies, which are attacking the endothelial cells of the newly graft. And once that one has happened, there's complement activation, and there's also attraction of the neutrophils, and neutrophils will destroy by lytic enzymes, causing injury. And in the process, platelets are activated, and there's clot formation inside the vessel. So if you do your examination at the lab, you look at the biopsy report, which are being taken from the graft, and mostly they'll be characterized by occlusions, neutrophil infiltrations, and they'll be able to find thrombotic occlusions within the lumen of the blood vessels of the graft. So that is the picture of the histology report, and this one was for the kidney. So in acute rejection now, it is vascular and parenchymal injury. So this is not antibody mediated. This is now mediated by the T cells. And in the process, you see, once the T cells have been activated, especially there is release of cytokines, such as interleukin 4 and 5. And these ones will activate the B cells, and which will differentiate to plasma cells, forming another allospecific antibodies that are able to attack now the vascular and the parenchymal cells of the newly planted graft. And by doing that, it causes injury to this particular cell. So these ones can begin after the first week of transplantation, where the T cells will respond to alloantigens, including the MHC molecules, which are present on the endothelial cells and the parenchymal cells. So another thing is innate immunity can also be activated through the natural killer cells pathway, and that would mount more injury to the vascular cell or the parenchymal cells of the graft. So the activated T cells will cause direct killing of the grafts or produced by cytokines. We remember in acute rejection, mostly it is mediated by the cytotoxic T lymphocytes, where now the donor or the allo-MHC of the donor, they interact directly with the CD4 cells of the, with the CD8 cells of the recipient. And in the process, effector CD8 cells are released. So these effector CD8 cells, they are able to recognize the donor peptide or the donor allo-MHC. So once they're able to, remember that all the endothelial cells lining are consisting of, all nucleated cells have got MHC class 1 on their surface. So once we have got effector or the cytotoxic T lymphocytes, they will traffic to the organ and then attack the cells directly. So once the cells have been attacked directly, they cause injury, and they cause, again, the thrombotic occlusions of this particular graft. So in acute rejection, T cells are the major player. It means that the antigens, the donor allo-MHC molecules has to traverse to the lymph nodes of the recipients. That's where they interact with the recipient CD8 cells. And then the CD8 cells will proliferate because they're now able to recognize the donor allo-MHC. And once they proliferate, becomes effector T cells, they traffic back to the graft, and then mount a very strong immune response to the graft, causing injury to the newly planted or to the newly introduced graft. So in vascularized graft, e.g. the kidney grafts, the endothelial cells are the earliest target of acute rejections, and antibodies mediate acute rejection if a graft recipient mounts humoral response to the vessel wall. So what happens here is once these particular cells have been, the T cells have been activated, cytokines are released that are able to activate the B cells. And then the B cells will differentiate into plasma cells, giving us allospecific antibodies, which in turn travels and attacks the endothelial cells of the graft. So in histological pattern, you'll be able to see transmural necrosis of the graft vessel walls with acute inflammation. And that's the picture. So that picture is just giving us the two, where now we have got the recipient T cells interacting directly with the endoparenchymal cells, lining the new graft. And as a result, they destroy or they cause damage and also inflammation to the cells direct. And they also recruit more inflammatory cells like macrophages to the site. And as we have said, they also, that process also give rise to alloreactive antibodies, giving us a picture that resembles that of hyperacute rejection. So the only difference here is that the antibodies that produce in the acute phase are not pre-existing, like in the hyperacute, but these ones have been initiated by the immune response. So if this is taken to the histology lab, you'll see the lumen. Like you can see the different parts. Those are some of the stains. So they'll also be able to find infiltration of lymphocytes, mostly T cells. If you do immunohistochemistry, the anti-CD3 will be positive for this particular grafts, because much of the T cells would have trafficked the graft and they have infiltrated in the tissues. So then the last one is graft vasculopathy, also known as chronic rejection. So this is more arterial than the venous. So it is characterized by arterial occlusion and it's not really thrombosis. What happens here is that there is the overproliferation of the layers lining the arterial walls. And through over time, because this is something that happens from 6 months, once or even 1 year after post-transplant. So even if a graft escapes an immediate rejection response, as we have seen in hyperacute, it can still undergo rejection years later, where a vascularized graft that survive for more than 6 months, they slowly develop arterial occlusion due to proliferation of intimal smooth muscles and eventually fail due to ischemic damage. So the arterial changes you can see in this picture, you look at the first one, A, the lumen is still wide enough and allow the blood to pass through. But as the immune response continue and more of tumor and the more of TGF, the tumor growth factors are released, and the interferon gamma, they increased. They start to what? To over-proliferate. And by doing that, the diameter reduces by size. But still, here, the blood can still pass in B. But now if you go to C, again, there is now thickening of the inner layer of this particular lumen. So by part D, it is almost occluded. So that is what happens. And this one is mediated by the indirect pathway, where now the peptides or the allograft has to be processed by the recipient antigen presenting cell, that is the dendritic cells of the recipient. Then once this one has been processed, they are displayed on the MHC class 2 and interact with the CD4 cells. So now what the CD4 cells does is that they will release interferon gamma and the tumor necrotic factor produced by the alloreactive T cells. So what happens here is that the smooth cells accumulation in the graft arterial intima isolated by growth factors and chemokines secreted by endothelial cells. So those growth factors makes the smooth muscles to start to overproliferate. On other words, forms extra layers bit by bit until it becomes occluded. So as the arterial lesions of the graft arteriosclerosis progress, the blood flow to the graft parenchyma is compromised, and the parenchyma is slowly replaced by the non-functioning fibrous tissue. So this is a hard tissue and it is non-functional. It continues to cause a necrosis of that particular arterial of the graft, and then the blood cannot pass through, and it will finally die or suffer ischemic damage, because it means that the graft will not be able to receive the nourishment to keep the cells alive. The process of graft fibrosis is also called chronic rejection, just what we have explained. And the picture there summarizes now how these ones happen, where we have got the the recipient antigen presenting cells, in this case, the dendricytes, processing the donor allo-MHC, or rather peptides of the newly planted graft. And so once that one has happened, it is displayed and interacts with the CD4 cells of the recipient. And in the process, once the activated CD4 cells have been activated, they end up producing things like interferon gamma and tumor necrotic factor. So what this one does, they stimulate the overproliferation or growth of the intima smooth muscles of the arteriole. So in the end, you have an occlusion. And they also recruit more macrophages to the site that induce damage to this particular cells. Because macrophages will release things like lytic enzymes that cause lysis to the endothelial cells lining the arterial walls. So the rate of rejection, as we have seen, it varies. If it is hyperacute, it's between minutes to hours. And there we are talking about the antibodies. These are pre-existing antibodies before transplant and complement active. We have seen that the injury, once the antibodies are attached to the endothelial cells, they activate complement, and therefore the end product is lysis. And if it is accelerated, maybe it doesn't happen almost immediately. You can see that one within days. And this one can be also initiated by reactivation of T cells. And acute phase, it takes days to weeks. Mostly we've said 1 week post-transplant. The key player there are T cells. And in acute phase, mostly we are talking about the cytotoxic T cell, that is the CD8 cell. In the chronic phase, months to years. The cause is mostly unclear, but mediated by the CD4 cells of the lymphocytes. Of course, CD4 cells, and of course, again, the antigen-presenting cells of the recipients. They have to process the donor peptides and then present them, and through that we release. So the picture here is just a summary of graft rejection and what happens during graft rejection. So in where the cursor is, that's now the naive T cell, is almost the first stage, the sensitization stage, where the donor allo-MHC molecules, they travel directly to the lymph nodes or the secondary lymphoid organs of the recipients, where they interact with the naive T cells. Then once the naive T cells are able to recognize them, they differentiate and proliferate and become effector T cells that will mount, respond. So if it is acute rejection, it will take the direction of the cytotoxic T cells, which will be able to interact directly with the donor peptide enzymes. And if it is if it is a chronic rejection, they'll be able to interact with the CD4 cells. But the CD4 cells will be able to stimulate release of cytokines such as interleukin 4, 5, and 6 that give us B cells. And then the B cells will differentiate into plasma cells that give us antibodies. So these antibodies are able to activate complement, that is the stage 4 there. They're able to activate complements. And once complement activated, they cause injury and again, activation of platelets, and we have formation of of clot inside the vessels. And we also have natural killer cells that can attack the cells directly. And in stage 1, we have also having macrophages. Macrophages are able to release lytic enzymes. Because CD4 cells are also able to release cytokines such as interleukin 12 that recruit macrophages to the site. So what these macrophages does is that they release the lytic enzymes. So the lytic enzymes, what do? They cause injury to the targeted graft. So having talked about the graft rejection in our previous webinar and today's webinar, we'll look at ways on preventing and treatment of allograft rejection. Number one thing is to reduce the immunogenicity of the allograft, that is tissue typing. Immunogenicity, the ability of this allograft to elicit immune reaction once transplanted in the recipient. So you reduce the immunogenicity by ensuring that there's a perfect match between the recipient and the donor, so that the the donors, the recipient immune system will be able to see the foreign or the allograft as self and not non-self. And that one, even if it will elicit an immune reaction, it will be too small to amount to a rejection. And of course, we are also doing immunosuppression. Immunosuppression now you do on the recipient side. You reduce the competency or the activated T cells as much as possible so that they are not able to attack the newly planted graft. And we can also achieve that by familial grafting. So familial grafting is that you look for the donor within the families. This one will reduce mismatch because these HLA molecules are inherited from both parents. And so therefore within the siblings, you are likely, chances of even getting the haploid match, that is at least half match, is very high in the families than when you are to go for a random donor. So then another thing is tolerance. Tolerance, against you make the immune system of the recipient to be as tolerant as possible to the incoming graft. So here we can use things like CTLA4 and also antibodies that are able to anti-interleukin-2, antibodies that are able to block the activation of T cells. So therefore making the recipient to be tolerant to the graft. They are not able to mount a stronger immune response. So the first one is reducing immunogenicity, as we have expounded in the previous slide. And we have said, number one, you minimize alloantigenic differences between the donor and the recipient. And number two, you identify identical ABO blood group antigens of the graft donor and the recipient. So you have to do ABO typing. You don't assume that it is organs, so you just pick any donor. You must ensure that the donor are matching with the recipient in terms of blood. And then you minimize class 1 and class 2 allelic differences between the donor and the recipient, that is tissue typing as well as HLA matching. So you also do cross-match for the HLA. So cross-match for the HLA, how it is done is that you will incubate the recipient serum and the donor lymphocytes. And then by that, you had complements. So if the complements are lysed and there's a positive, remember if the recipient are having antibodies towards the donor grafts, in this case lymphocytes, because that is what we are interested with, the HLA in the lymphocytes. What will happen? The antibodies from the recipient serum will be able to bind this particular HLA or lymphocytes. And once that one is done, if you had complement, what happens? There will be activation of complement and there will be lysis. So that will be a positive reaction. So in that case, those are incompatible donors and you do not consider that donor for that particular recipient. So that's where the lab plays a very critical role because we are a laboratory profession. We have understood the immunology behind it, but now the complex part, what we are talking about, the CD4 and all that. So our role here is now to minimize the rejection. So by doing that, we have to ensure that the donor and the recipients are HLA compatible. That is, they're matching almost 100% if we can achieve that. And also their blood type. Because remember, if you take a graft from, let's say, type A, and then you give type B, there will be incompatibility. And here we are talking about IgM. This is almost immediately. And IgM is a very good complement activator. It will be able to activate complement very fast compared to even IgG mechanism. And then what happens? There will be hyperacute rejection almost immediately within minutes of the graft. So the donor and the recipient typed for the ABO blood group, as we have discussed, and also the MHC antigens. The HLA that are normally typed are HLA-A, HLA-B, and HLA-DR for predicting the outcome. So HLA, in the previous presentation, we talked about the classes of HLA. We have got MHC class 1, MHC class 2. They are inherited as a unit. and also MHC class 3. So MHC class 1, we have got HLA-A, HLA-B, and HLA-C. And then that of 2, we have got HLA, DP, DQ, and DR. So MHC class 2 mostly plays a role, or it interacts more with the CD4 cells. So it mostly plays a role in the chronic rejection. While class 1, which is present in the surface of all nucleated cells, plays a role in the acute rejection, mostly interacting with the cytotoxic T cells of the CD8 cells. The HLA class, the MHC class 3 are mostly complement the C4A and the C4B, the C2, and tumor necrotic factors, mostly complements. And they have no role in antigen presentations. The one for the class 3. So in familial grafting, the transplantation within families significantly reduce the allele mismatches because of the inheritance patterns of HLA. We have said they are inherited as a unit. And in general, there is a little crossover within the locus, and the whole locus is usually inherited. So other tissues antigen that triggers far less vigorous rejection responses, that is the minor histocompatibility antigens, are encoded outside the MHC locus. And we also explore for the minor histocompatibility complex, chances of causing graft rejection are minimal. But where there is so much differences, the allelic differences for the minor histocompatibility genes, they can trigger a rejection or an immune response. So tolerance, it's induction of donor-specific tolerance, where the allograft rejection may be prevented by making the host tolerant to the allo. You try as much as possible to make the recipient tolerant to the allo antigens of the graft. So this one is making the activated T cells in the circulation or in the system of the recipients to be energy. That is the peripheral energy. Peripheral energy simply means they are unresponsive. So either you block the co-stimulatory signals, things like CTLA4. Remember, CTLA4 is the one that is the co-inhibitory, is the one that remove. Once the T cells have been activated, the first signal is the recognition of the peptide, either displayed on either class 1, MHC class 1, or MHC class 2. So MHC class 1, that one will be binded by CD8 cells. They have got what on their surface, the T cell receptors of the CD3. So that is the first signal. So once that one is done, we have got the second signal of the activation. That is now the co-stimulatory signal. So the co-stimulatory signal is where the CD28 on the surface of the T cells will bind the B7.1, that is the CD80, and B7.2, the CD86, on the surface of the antigen-presenting cells. And once that one has happened, the co-stimulatory signals have been done, it will stimulate the second process of or transcription of the T cells, and also differentiation into effector cells, releasing of cytokines and all that. So that is what is being done, inhibition of T cell activation to make the recipient as tolerant as possible. So they can be given anti-interleukin-2 receptors, antibodies. So what these ones does, they block the binding site for the interleukin-2. And once this one has happened, they block the activation pathway, and the T cell become inactivated. And by doing that, they're not be able to respond to the new graft. So having explored reducing immunogenicity and also the tolerance, or making our host as tolerable as possible to the new graft, we can also use immunosuppressive drugs in preparation of the recipient to receive the new graft. So the drugs that are used, and these drugs falls in the following categories. One is corticosteroids. So what corticosteroids does, they are anti-inflammatory response, which means they inhibit the cell division, particularly that of lymphocytes. Remember, once the T cells are activated, there is that proliferation state, like they multiply in number, and they are now effector. They can able to recognize the allograft or the peptides. So the corticosteroids, such as the prednisons, what they do is they block that response. And so once they block that response, we'll not be able to generate the effector T cells that will traffic and damage and damage the endothelial cells or even the parenchymal cells of the transplanted graft. So another group of drugs is calcineurin inhibitors. So what calcineurin inhibitors does, they block the calcineurin, a phosphatase required for interleukin-2 transcription. So mostly the most ones that I know we have interacted with in our lab, cyclosporin is one of them, and another one is tacrolimus. So cyclosporin and tacrolimus, they have the same mode of action, only that their binding sites are different. For example, tacrolimus, they bind to the FK506 proteins, that is an immunophilin, and then form a complex with the calcineurin. And so once that one is done, they dephosphorylate the NFAT, that is nuclear activated for the T cells. And that is what is required for transcription of what? Of interleukin. So once that pathway is blocked, no interleukin-2 is produced. And so therefore T cells cannot be activated. For the cyclosporin, it will bind to the cyclophilin and forms a complex with calcineurin and again dephosphorylate the NFAT that is required for transcription of interleukin-2. So another groups of drugs are mTOR inhibitors. Examples include sirolimus. Those ones, they block the mammalian target of rapamycin. And that one is a phosphatase, which is involved in cell proliferation and protein synthesis, and also T cells regulators. So once that pathway is done, is blocked, we cannot have more, T cells proliferations. And then we also have purine inhibitors. This one now plays roles in the cell production, especially the lymphocyte cell line. So disrupt the synthesis of DNA and RNA. Examples are azathioprine. It's a drug that can also be used to achieve that. And I know here, the lab plays a critical role because most of these drugs work under very narrow therapeutic range. And so what we do as laboratory personnel is to maintain that effective therapeutic range. And by doing that, we are preventing rejection as well as avoiding toxicity. Yes, because at high levels, they become toxic to the patient, especially tacrolimus. If it is on high dosage and it is not well controlled, you might not be able to differentiate whether the failing graft is actually due to the rejection or the drug itself, because it will result into acute kidney failure, even that of the planted graft. So there is therapeutic drug monitoring, and this is done in our biochemistry lab. The table just summarizes what we've discussed in terms of drugs. So inhibitors of DNA synthesis, those are the purine inhibitors, and we've talked about azathioprine. Said what they do is they stop the T cell from proliferating in response to alloantigen. And a mitotic inhibitor that targets in the S phase of the cell cycle, then block the synthesis of the inosinic acid needed for production of DNA. They also stops the B cell proliferation. So the B cells cannot, again, differentiate into plasma cells, giving us antibodies that would injure or would attack the endothelial cells of the grafts. Again, when they stop the T cell proliferation, what happens? We are not able to get the effector T cells that will be able to destroy or kill the cells of the newly planted graft. So the next one is inhibitor of cytokine production. We've talked about cyclosporin. We've seen their mode of action. So like cyclosporin, they'll bind to cyclophilin, and then they block the calcineurin, preventing the activation of NFAT. They dephosphorylate the NFAT, and the NFAT is needed for the transcription of interleukin-2 or cytokines, because it is the NFAT that moves into the nucleus and then initiate that transcription. Then we have got inhibitors of cytokine binding. So here we are now using antibodies. That is the interleukin-2 receptor-specific monoclonal antibodies. So these ones will block the sites for binding of interleukin-2. So if they are not able to bind, then they'll not be able to mount response. They'll not be activated, and they'll not be able to recruit more T cells or more activated T cells to the site. Actually, what they do is to recruit the cytotoxic T cells that are able to mount direct killings to the newly planted graft. So we also have another class of graft, fungal metabolites, inhibitors of cytokine receptor signal transduction. So that is the mTOR inhibitors, the likes of sirolimus. So those ones, again, we have talked about them. They inhibit the production of T cells. So this diagram, what it does is just summarize the immunosuppressive drugs and their target. Like, for example, you say the first target, the first signal is when the T cell receptors, it could be either on CD8 or the CD4, binds the peptides. And the peptides here are class 1, MHC class, the peptides here are presented by MHC class 1 and MHC class. Another thing that we need to know is MHC class 1, they normally present those endogenous peptides or pathogens if it was an infection like bacterial or fungal. So those ones which have been processed through the proteolytic pathway or the cytocytic pathway, where we have got proteolytic enzymes degrading these particular peptides. In this case, we are talking about the allografts and the halo-MHC. So the smaller peptides, the ones that are between 8 to 11, those ones will be displayed on MHC class 1, and they will interact with the CD8. So in CD8 here, those are the T cell receptors to the CD3. So we'll have a drug that is acting on it. You can see anti-CD3, MB, it is an antibody. So it prevents that binding. So by preventing that binding, the first signal is eliminated. And then also we'll have another drug known as belatacept, and it will be targeting the second co-stimulatory signal. We also have another co-activation signal, but it might not be important as the co-stim, because without co-stimulatory signal, the transcription or the inward processes cannot take place. The co-activation signal is now where the CD40 ligand on the surface of the T cells binds the CD40 on the antigen presenting cells like macrophages, the dendritic cells, or the B cells. But now this drug, belatacept, is targeting the co-stimulatory signal. That is the it prevents the CD28 from binding with the CD80-CD86. That is the B7.1/7.2 on the surface of the APCs. And we are having another drug where the pointer is, that is basilzimab, is one of the interleukin-2 receptors antibodies drugs. So what it does, it blocks the binding of interleukin-2 to their receptors. So it blocks that signal 3. And we are having mTOR inhibitors, the likes of sirolimus. And then another one, if I move this other side, we are having calcineurin inhibitors. We have got cyclosporin there and the tacrolimus. So what they do, you said, they bind to the calcineurin, only that the binding sites are different. For the tacrolimus, it will bind to the FK506 protein. But for the cyclosporin, this one will bind to the cyclophilin. And then they will form a complex that dephosphorylate the NFAT. And by doing this, there will be no interleukin-2 transcription. And by doing that, no interleukin-2 will be released. And once this one has been blocked, no more effector T cells will be recruited to the site to damage the graft further. And then we are having another group of drugs down here, these ones which result into immunodepletion. There's another one known as alemtuzumab, which blocks the CD52. And then we also have those ones which purine inhibitors, the likes of azathioprine, mycophenolate, and methotrexate. So this one, what they does, they prevent the DNA synthesis for the lymphocytes. So by blocking this pathway, there is no T cell proliferation, and there is also no B cell proliferation. So the recommended dosage, mostly they will have a combination. This is a combination therapy. So most of the time, most of the patients will be put in on a calcineurin inhibitor, either cyclosporine or tacrolimus, or they can be put on purine inhibitors, those ones which inhibit the proliferation of the growth. That is azathioprine. So you can find a patient taking azathioprine, tacrolimus, and then a corticosteroid, such as prednisolone. So it was a short webinar. So we are done in the next 5 minutes. So as we wind up everything, at least we've seen how important the graft rejection looks like, and the pathways, and also how to prevent, the same. Only that now, what is the role of laboratory professionals in prevention of graft rejection? So the first role is in the pre-transplantation. So here in the pre-transplantation, we ensure that the donor and recipient matching. Matching is not just based on the ABO typing, like when we are giving the blood. The matching here, the most significant one is the HLA matching. So we have to ensure that the donor and the recipients are HLA typed and they are compatible in terms of their HLA and HLA antigens, and also in terms of their ABO. So by doing that, we can arrest the pre-existing antibodies that would mount to hyperacute rejection. So another one is pre-sensitization screening. So in the pre-sensitization screening, what we do is the serological testing. So serological testing here, you determine the pre-existing antibodies from previous blood transfusion. It could be from pregnancy and transplants. So those are some of the things that we consider. So we want to eliminate the possibility of having pre-existing antibodies in the recipient system as much as possible. So by doing that, you can do the cross-matching of the HLA. So first, you will start by typing the HLA. And typing the HLA, you use PCR so that you know whether this patient is having HLA DP, DQ, DR, and which one. Remember, they are highly polymorphic and highly polygenic. There's a lot of variation, and there is also different genes encoding for this HLA matching. And that's why we can never have the same HLA genes, even if we are twins. You can never have 100% match. And have to think of it, assume if the whole populations were having HLA-A, for example, HLA-B, for example, and then there's an infection that targets HLA-B, the whole population will be wiped out by this particular infection. So it is the HLA that gives us that immunity towards that diversity to respond to millions of antigens, millions of microbes and all that, and keep our immune system strong. So one of the disadvantages of immunosuppression is that we are subjecting, the recipients are susceptible to opportunistic infections. So that's what the pre-sensitization does. Sensitization screening is all about. We eliminate possibility of this patient having been sensitized before. Because it could be they have received a transfusion or even multiple transfusion before, or this patient could have suffered multiple pregnancies, or this patient would have received transplant. And in that process, they got sensitized. And so therefore they are having the anti-HLA in their system. You introduce a new graft and then they are able to mount a very strong immune response directly to that particular graft. So another role that the labs play is post-transplantation role. So number one in the post-transplantation role, as we have discussed, is immunosuppressive drug monitoring, ensuring that the levels are within the effective range and maintaining the balance between preventing the rejection and avoiding toxicity. So some of them, like tacrolimus, they exist in a very narrow therapeutic range. And so you have to maintain that to avoid toxicity at the same time we are preventing rejection. And the therapeutic range will vary depending on the type of allograft. The ranges for lungs are not the same for the liver and even for the kidney. So for the kidney, for example, if it is an adult, before 3 months it's around 8 to 12, and then 6 to 9, and then after 3 months it moves to 4 to 8. So the dosage, the therapeutic range will vary. And again, during the early phase of post-transplant, the patient have just received the graft, the monitoring will be more frequent because the doctors have to, this is pegged on patient per patient because the way the response are different. So when you have a patient who have just received a transplant, you monitor very closely so that we are able to establish the therapeutic range for that particular patient. And they monitor and they see at what dosage do they tolerate best. And then also they monitor the outcome, like stabilization of the organ. If the organ picking well, and it is picking well at what dosage. So until they find out that, they tend to do the monitorization more frequent compared to somebody who have been with a graft for longer period. So another role is on graft monitoring. So for graft monitoring they do organ function tests. If it is kidney, they will be able to monitor by kidney function test, for liver function test, and also biopsy analysis, as you had seen in the previous slides on how the biopsy looks like. If it is hyperacute rejection, what you expect to see. If it is acute rejection, what you expect to see on your slide. And then if it is chronic rejection or graft vasculopathy, what we expect to see on the arterial lumen. So they can follow up with biopsy. They can follow up with the biopsy. That is if we query rejection. So you want to see the extent of the damage. That is the inflammatory and the cellular damage. So biopsy is done to check on the inflammatory changes and the cellular damage. And then the organ function test, if the new organ, if it is kidney, if it is picking up and restoring the lost function. And then the last one is infection monitoring. So most of these patients, will see them doing a lot of microbiological testing, such as Epstein-Barr virus, BK virus, cytomegalovirus. This is because they are highly susceptible to opportunistic infections because they are on long life immunosuppressive drugs. So the immunosuppressive drugs is there to allow them live with the new leaf, with the graft, and at the same time avoid the immune reaction to the newly planted graft. So while doing this, remember, they are not able to fight these other infections, and so therefore they are predisposed. So the doctors will just keep on checking whether these patients are suffering from these particular opportunistic infections. And that is also the reason why we do the therapeutic drug monitoring. So you avoid the level of toxicity. Because again, if the dose is too low, then the rejection mounts. And if the dose is too high, then the toxicity mounts. Yeah, so that marks the end of our presentation. But what I have to say is that prevention of graft rejection or handling of organ transplant patient is a multidisciplinary approach. It involves different personnel, pharmacists to regulate to monitor the dosage, the nurses who administer these drugs, the doctors, the transplant physician who does the therapeutic drug monitoring and all that, and then the lab, which plays a very key role. in maintaining. So there is also a lot that goes for in preparing the patient for this particular procedure, including the financial burden. So you have to, the nurses have to give the appropriate counseling, like they have to make it clear to the patient what the journey look like, what they will have to go through post-transplant and even pre-transplant, and the financial costs that come with it. Because again, the psychosocial support is also important to allow this particular patient to adapt and achieve his or her normal life back. So over to you, Fred.
Francis, thank you. This was such a wonderful presentation. I've really enjoyed the presentation, and I'm sure most of the participants here in have also enjoyed. Very well, very well, very well done. I can see a lot of comments in the comment section, and maybe I'll just read a few, and then we'll get to a few questions. So if you have a question, you can get into the Q&A section and just write your question or concern. We shall be able to read it. Godfrey Ogula is saying, nice presentation. Thank you, Godfrey, for joining. Duncan Ngara is saying, this is the best I've ever joined. It's speaking directly to my heart. Thank you, Duncan. And many, many of you who have written your comments here. This is Wilfred Moriasi saying, this is a beautiful presentation. We are dealing with a young person who's having this organ transplant rejection challenge. Linus Kipchichir is saying, very educative session. Stephen Gatohi, nice topic and very educative. Johanna Milgo, very precise, informative presentation. So colleagues, I may not be able to read each and every comment, and you will pardon me for that. But for those of you who have really enjoyed the presentation, I guess I've also enjoyed. We continue to learn, and maybe at this point, we'll pick a few questions, and then we proceed that way. So Francis, if you can hear me, I'll pick the first question. This is from Jepkoril Chelal. She's asking, which type of graft rejection is cell-mediated? Elaborate the several cells in this cell-mediated type of rejection and their functions. So I don't know whether you heard me, Francis.
Yes, I heard you.
Yes, so maybe she's asking the type of graft rejection that is cell-mediated.
Self-mediated graft rejection. Okay, I know there's a bit of confusion. There's something we refer to graft versus host disease. This is now where the newly transplanted graft, instead of the recipient eliciting immune response to the graft, it is the graft that does the same, where now the donor lymphocytes are more competent compared to that of the recipient. So what they does is that they attack the key organs of the recipient. Most of the time it will be the skin, the gastrointestinal tract, and the liver. Those are the ones that will be mostly affected. So for the graft rejection, it's the other way around, where now it is now the recipient, the donor lymphocytes of the recipients. Those are the ones that are now targeting the newly planted graft. And it is expressed on those three clinical stages that we've discussed: the hyperacute rejection, where the recipients are already having pre-existing antibodies. And then the second one, we've talked about the acute rejection, where now the T cells, acute and chronic, are now the T cells. The T cells, and here we CD8 for the acute and the CD4 for the chronic rejection. So that's how the rejection pattern takes place. I hope that has answered the question. Next one.
Yeah, very well. That is okay. I'll pick the next one from Wilfred Moriasi. What contributes to multiple pregnancies leading to hyperacute rejection or general rejection? Chronic problem, we understand it's a long-standing problem. My concern is, does chronic rejection refer to a continuous process, or it occurs a long period of time?
So for hyperacute rejection in multiple pregnancy, comes in situation where multiple pregnancy, maybe there is fetal-maternal exchange, and through this, the mother, because we are talking about now the mother being the female being the recipient in this case. By doing this, they are sensitized. Sensitized means they have released anti-HLA. They have formed anti-HLA molecules in their system. So these anti-HLA molecules are pre-existing in their system, and when they received graft from their children, the ones that they have born, maybe at one point your mother or your father need a graft or a kidney transplant, and you are to donate. And when when the mother was pregnant with you during that time, there was kind of sensitization, and the mother during that period developed anti-HLA toward this particular HLA molecules in the children. So if he or she received, she received this particular graft, they will amount an hyperacute rejection. Why? Because the anti-HLA will be able to attack the newly planted graft in matter of minutes and results into thrombotic occlusions. So for the chronic rejections, patients can survive the acute phase and the hyperacute phase. But again, after 6 months or maybe after 1 year, they develop the chronic rejection. So chronic rejection is a gradual thing, it's a process thing, and that's why they have to be continuous monitoring so that the doctor is able to pick it. Let's say in the first 3 or 5 months of transplant, the kidney is picking well and the creatinines are okay. And then 2 months down the line, they start to derange. That is a sign of a rejection that is building up. So to prevent that, they can do a biopsy and then check. So if histology reveals, then they will have to adjust the dosage of the immunosuppressive drugs that they are giving this particular patient to at least make the patient tolerant to the new graft. Yeah. Next question.
Thank you, Francis. That was you ably answered that. So I'll pick this one from Benson Lusenaka. In case of the rate of rejection, can we also associate it to incompatibility?
Yes, incompatibility in terms of HLA and in terms of blood type, we have talked about it. Because in a case where the patient is not having, maybe you are having a 2/6 donor. You've searched for donors and donors and donors, and you are not able to find it. You are getting like 2/6. That is not even half a match. Half a match should be at least 3/6. If good, you get at least 5/6. That is the 6 HLA haplotypes are matching with the recipient. So here, where there is huge allelic difference between the recipient and the donor, they are able to form those anti-HLA antibodies. So, and again, maybe if the donor is, the recipients are already having anti-HLA antibodies in their system, or maybe incompatible anti-ABO, or even the IgG, maybe they are rhesus negative patients and they were sensitized and they developed the rhesus antibodies in their system. So in that case, it means you will look for a graft from a rhesus negative donor so that you don't give them rhesus positive graft. Because by giving them rhesus positive graft, the rhesus antibodies are IgG and they'll be able to amount hyperacute rejection. So the rate could be that of hyperacute or acute. It can happen within a week or within minutes to hours, depending on the initiator. If the initiating process is the pre-existing antibodies, then within hours. But if it is the T cells, then it will take place like a week. Yeah, so that will move to acute rejection. The next one. Yes, Fred. Hello, did I lose you?
Francis?
Yes, I can hear you now.
Okay. Apart from this, from Erica Wonder, apart from DXM, what other lab tests do we use to determine compatibility, to determine tissue mismatch and avoid rejection?
So in HLA typing 1, we say the first thing we do is you type the HLA. Of course, cross-match, I don't want to speak much about it because that one we are all aware of, something that we do on a day-to-day basis. Of course, whatever we do in day-to-day basis, where you match the blood of the recipient and the donor, you have to ensure that there is no regular antibodies in the system of the donor towards the blood, I mean, the ABO, the rhesus or other blood group antigens. So for the HLA matching, one, you can do the, number one, you have to type. So you do the PCR, you do the HLA typing so that you identify what is the exact type HLA. It could be DP1, DP2, I mean DQ and DR. So what specifically is present in the donor and that in the recipient, and then you match the two. So once we have established this, then we move to cross-match. Cross-match, you can use flow cytometry, or you can use the cytotoxic method. Cytotoxic method is where you are incubating the serum of the recipient and the lymphocytes of the donor, and then you add complement. So in case there is any anti-HLA in the system of the serum towards that of the, I mean, in the system of the recipient towards that of the donor lymphocytes, the anti-HLA will be able to bind the donor lymphocytes. In the process, activates complements, cause lysis, and that will give us a positive cross-match test. So it means those two are incompatible. Yeah, so those are other tests that you can do to match. Mostly it is in the HLA, so you'll employ flow cytometry, cytotoxicity, and you'll also employ PCR. For PCR, you can be able to do sequencing so that you know exactly even the specific allele in both the donor and that of the recipient. For the cross-match, we are just trying to rule out the antibodies, the presence of any antibodies in the system of the recipient that is directed towards the donor HLA molecule. Yes, Fred.
Very well, very well. That is great. So maybe I'll bring up the next one from, okay, this is John Kuche. How long can a patient use immunosuppressive drugs as far as prevention of graft rejection is concerned? Thank you, John, for the question.
How much? I didn't get that.
How long can a patient use immunosuppressive drugs?
Yeah, okay. So how long? We said it is for a lifetime. As any patient who have undergone transplant, it is for a lifetime. What differ is now the dosage. At early stages, the dosage tends to be high, and then they will reduce. And we said the frequency of monitoring, like if it is a newly a transplanted patient, the monitoring can be done 2 to 3 times a week, and sometimes even daily. And what they are trying to do there is to establish the therapeutic range for that particular patient. And again, the interest of the doctor is to determine at what dosage of the immunosuppressive drugs that does the patient tolerate best. So tolerate best in terms of preventing, they're not developing any signs of rejection. And then another one, there is no toxicity. Yeah. So it is for a lifetime. So once let's say 4 years, 1 year after, and the patient is doing well, and then grafting has been done successfully, and there is signs of life in this particular, maybe even the patient no longer, even the creatinines are now back to their normal ranges, and there is no any sign of graft rejection. So the doctor will reduce the dosage like that. Yeah. And also the intervals of monitoring will also increase. If they were doing it weekly, they could now do it monthly. Yeah. but they will be on immunosuppressive drugs for lifetime. What the doctor will be checking are also presence of opportunistic infections, so that in case of any, they know what to do and also to address them on time. Next question.
Thank you for that. This is from Wilfred Moriasi saying, outside of what maybe you have covered, but how does memory cells contribute to graft rejection?
Memory cells will contribute to that graft rejection in essence that this patient, they have received even bland is a tissue, maybe it is a transfusion and they have developed, there was a mismatch. It could be granulocyte transfusion, and then the patient develops anti-HLA. They reject the lymphocytes of the donor. Then, so the immune reactions had taken place, and the patients now, or the recipient in this case, now has memory T cells in their system. So in the process, this long process of now activation, sensitization, effector cells, this will be more immediate because the memory cells are able to recognize the graft antigens immediately and mount a very strong immune rejection. It will be something that resembles hyperacute rejection. Yes. Go another question.
Yeah, Boniface Story saying, recently I saw a patient who has undergone kidney rejections 3 times. She's planning to do a 4th transplant. Okay, I think he's asking, is it advisable to continue with the transplant? I don't know if you have anything to say about that, but let me ask.
The patient have undergone 3 times, it's quite a lot, and maybe they have lost the graft actually through that rejection. The fact that the patient is even looking forward to receiving a 4th one. Only that now the gaps will be closed almost 100%. So in this case, they have to try as much as possible to look for a 100% match, which might be impossible, especially if the patient here does not have a twin, because the person that you find almost a perfect match with is a twin. But now they will really have to. And another thing that they'll also have to do is to, if they were doing familial grafting, like the donors within the family, they'll now try to look for donor outside the family. Because maybe there is an anti-HLA that is already in the system of the donor towards the HLA haplotypes within the family. So to avoid that kind of recurrence, they have to go outside now, maybe even distant relative or somebody that is unrelated. Then just try to find if they can find a donor. In this case, they try to almost, even if it is a 5/6 donor or maybe 4/6 donor, something of that sort. Yeah, to minimize that chances of rejection again. Sorry for that patient. Next question.
Okay, so the next question is from this is an anonymous attendee. Okay, let me read this from Irene Mwai. That was very informative. My question is, when you talk of multiple pregnancy causing sensitization in graft rejection, is it subsequent pregnancies or more than one fetus, twins or triple?
As we had expounded earlier, it's not really tied to whether twin. It can happen with any pregnancy. And this we said in cases where the mother would have developed anti-HLA towards the fetus. So they already have these antibodies in their system. So therefore they are presensitized. They are presensitized in their system. If it is a case of a rhesus negative mother, then it would explain best, especially in cases where they did not take ROGAM, to at least remove the irregular antibodies. So in such a case, it means the mother will become sensitized towards the rhesus positive fetus. So if in future they get transplanted from any rhesus positive donor, not necessarily within her family, they are likely to mount hyperacute rejection. So the issue here is on the sensitization. Sensitization here, I mean the mother having possibility of developing anti-HLA in their antibodies or or rhesus antibodies in their system. Or even maybe it is a blood group O mother becoming pregnant with an A or B child. So where there is that ABO incompatibility, they have maybe anti-A or anti-B in their system. Those ones still can cause hyperacute rejection in case of transplantation. So that is what we mean. And you remember multiple pregnancy, which means this mother is giving birth severally. So chances of hemorrhage, chances of breakage are very high, and chances of the mother getting sensitized are also very high. Yeah. Next question.
I'll bring this from Lamek Ontweka. What causes of own person skin graft rejection?
Skin graft rejection is where that is now autoimmune, huh? It's more of autoimmune, and it is mediated by the T cell. Yeah, so in case the patients have autoantibodies in their system, then that one will cause the autograft rejection for the skin.
Thank you very much. Otherwise, I think we've come to the very end of today's presentation, and it was indeed a very wonderful one. And at this point, I just want to take this back to the speaker for his closing remarks.
So thank you so much, everybody, for listening and joining to today's webinar. I believe it was an interactive session, of course, and we have learned. I've also learned something. We've also learned something throughout this particular presentation. What I can say, graft rejection in future, it will become common in our country because we have got more transplant setting up. Again, the lifestyle diseases are becoming more. We are seeing more patients with kidney cases, maybe kidney failures, and they might need a transplant, and even liver or even other organ transplant. So it is one area that is still new, but with time, and again, with the lifetime diseases that are settling in, it will become more common. But already we have got so many patients who have been transplanted before, even at the Nairobi hospitals, who are doing post-transplant care. Like this therapeutic drug monitoring, we do all of them at the Nairobi hospital. For tacrolimus, cyclosporin, all those. We do them. So most of these patients, you find that maybe they were transplanted outside the country. Some in India, some in whichever country. But also we have got more transplant centers in Kenya. So in future, we might have more patients who are transplanted here. So we might be dealing with these cases right from onset, from the pre-transplant, the complication during the surgery and all that, after transplant, yeah. And you'll also meet, there are also patients who have survived with this graft for so many years, yeah, and they're doing well. So it is a long journey. And as we have said, it's not all about the science we've discussed here. The psychosocial support is very important to these patients. So even if you missed them in your lab, just understand them, understand what they are going through, and the fact that they have to be immunosuppressive drug for a lifetime, the fact that they are highly susceptible to opportunistic infection, the fact that they have to be on close monitoring. It's not something that they will come today, they do the surgery and then they move on. They have to be seeing their doctors almost for the entire point of their life. So that's all. And I'm wishing everyone the best in their respective areas. Thank you.
Francis, thank you so much. And I want this opportunity to thank you for finding time. And on behalf of Lab Medicine Society of Kenya, thank you to everyone who found time to tune in. And until next time, have a great evening. Thank you.